Mic is good? Awesome, thanks. So it's a delight to be here with you. Thanks for the warm introduction. Vinny, thanks for that great talk, kind of diving into clinical side of things and really what do we need to do clinically to really improve health outcomes. One of the things I'm actually going to talk about is focusing on the other side of delivery, which is operations, and thinking about not necessarily how we do a better job clinically in diagnosing people, but what do we need to do as a system that has worked kind of in a way for so long, bolted on technology, just that's accumulated so much tech debt over these years, and now we have this opportunity to really modernize our healthcare operations, and what are the sort of challenges we can solve through kind of modernizing our healthcare operations, and what does that agenda look like? So here's my one disclosure. I serve on the Consumer Health Advisory Panel for Google. And so a little bit about me. So I'm a Chief Health AI Officer in a health system. What this means to other people is that I think all problems are solvable with AI. But what this means to me is that there's a lot of actual problems that are health system problems. And what I'm tasked to do is to really think about what of those problems are actually potentially solvable with AI, and what are the different ways we need to design our systems where AI actually can lead to better outcomes. And that's no easy task, and it often means a lot of difficult change, but that's kind of the role that I have within that system. I also am fortunate to lead an AI lab within our Jacobs Center for Health Innovation, which is essentially kind of a way of having a scholarly team taking a rigorous approach to trying to measure the things that we're doing so that as we change the system, as we think about new ways to deliver kind of care as part of the healthcare operations process, that we have a way to actually generate scholarly output and actually think about that in a critical way, which often you'll notice there's a dichotomy between the people who do research in healthcare and the people who do operational work in healthcare. And so this is kind of an effort to try to bring those two things together. While it seems less relevant, I'm also a practicing kidney doctor. And what I will say is that for folks in the room who are looking at potentially doing a career that's a blend of science and medicine, that my first week that I spent in the health system practicing as a kidney doctor at UC San Diego, I learned more about the health system in that 1 week than I had in probably the year of people describing the health system to me. So I think both the opportunities and challenges become extremely apparent when you're even just a few days in the system, and you start to see how the numbers that you were seeing on dashboards, what do those viscerally feel like when you walk down to the ER? You get kind of that connection to the system, and I think there's something about that really makes the system come to life. And so as you're thinking about tackling problems, you're thinking about it in a really applied way and in a realistic way, so not in a kind of I have a solution to sell you kind of way. My journey in healthcare operations started back when I joined the faculty at University of Michigan. I've always been interested in kind of both the innovation happening in technology, but mostly in terms of when we take that innovation and we apply it, what do we actually find? When the rubber hits the road, do things actually work? And I had the position at University of Michigan of leading AI governance and helping to establish AI governance. And one of the early things that we kind of dove into was, do we want to turn on specific models and actually use them in clinical workflows, and how? And at that time, the prevailing wisdom is that non-interruptive alerts don't actually work. So the only way that you can have an effective AI is to enable interruptive alerts. But when we actually enabled these in 1 or 2 units, we found that in those hospital units, none of our outcomes were changing. So we went back to the drawing board and said, let's ignore those 2 units, look at the rest of the hospital, and try to understand what's actually happening at the intersection of when that AI is hitting the bedside that's driving us not to have better outcomes. And that led to this work where we looked at a sepsis model deployed widely across the country, including within our electronic health record, to try to understand at University of Michigan, why is this model not working and actually achieving those kind of better outcomes when we talk to our quality committee who's trying to manage this on the operations side. So what do we find? We find that most people around the country are using this model to decide to prompt someone to start antibiotics. And yet by the time this model fires, most people are already on antibiotics. And so that was fundamentally what was happening, that was kind of only uncovered as we thought through what are clinicians doing with this information, how are we using it, and trying to understand, when we link model performance back to clinical activity, why this system is not working as well as it should be. This was surprising at the time. and it led to kind of a lot of press and obviously a lot of controversy around, is that actually real? Is this a reproducible finding? Is this kind of a one-off thing in this one health system? But I think that this also led to policy impacts and trying to understand the way the FDA regulates software as a medical device was tweaked as a result of finding that these AI tools don't always work the way that you expect them at a system level. And ultimately, this led to changes in White House policy. And so I think what I recognized was that the governance and the day-to-day operations work that a health system does in working with AI actually is often connected across systems. It's a shared experience. And there is clear implications, not just to the individual people working within that system, but also to other ways in which the system gets put together that impact the kind of care that our patients get, and actually that translation of, does implementing these tools actually lead to better outcomes, and to try to figure out how do we make sure that it does, as opposed to the current state where we often just don't know. The systems go in place and we don't know. Okay, so before I dive into healthcare operations, Vinny talked about it, but I'll just talk about it in an even simpler way. What are health systems? And I would say health systems are a way of organizing the care and resources that people need when they get sick, and the resources that we need to prevent people from getting sick. They often takes place at home. Sometimes people live in a nursing home, skilled rehab facilities, clinics, ERs, hospitals. And so health systems are essentially trying to figure out, how do I organize these resources so that the people who need them, the sick people, not the worried well, are the ones who get the resources? There's a saying in healthcare that if you know one health system, you know one health system. And so even though on paper, two systems can look the same, they have the same set of services, the way that it feels to work in those systems can be polar opposites and feel very different. And so I think that when we think about how we might use AI or how we might use technology within these systems to improve care, it is really helpful to be in the system and to understand, how does that system actually work? How are the things put together? Because the same set of services can be put together in a different way and lead to very different challenges that are solved in a very different approach in terms of how you bring AI into the picture. Okay, so healthcare has two components. I think Vinny talked a lot about the first one, which is how do we organize care and deliver the best possible diagnosis and treatment, and that includes AI-based triage early up front to try to make sure that we direct the resources to the patients who need them. Healthcare operations is something that often happens behind the scenes, right? It's ensuring that care is as safe and efficient as possible. It's the sort of thing that you do because you want people to get the best possible care. So if you have the best doctors or the best treatments, but it takes you 6 months to get in to see someone, you can't possibly be getting the best care. So this is kind of the kind of why it's important to think about AI when it comes to operations. It's not that unlike Amazon in some ways. There's a team at Amazon, right, that presumably works on their collaborative filtering algorithm and makes sure that when you select one item and another item, that the next couple items it shows you are the most likely items that you'd want to buy. And Amazon does a pretty good job of that. But if Amazon didn't get you the deliveries to your house on time, all of that would be a moot point. And I think that's the issue we have in healthcare. We have the ability to do amazing things, amazing things, but we don't have the operational infrastructure to actually deliver those things to you in a way that leads to better outcomes. And we've seen that from the chart that Vinny showed, where we're spending more and more money, we're seeing diminishing returns on that money. And some of that is because our operations are problematic, even though our clinical care continues to get better. So even though most of this talk will be about healthcare operations, I do want to remind folks, in case you're not in the clinical care space, that the last few years has been just an amazing time to be in healthcare. CAR T therapy has basically made incurable cancers curable. Stuff that we were taught in med school that you can't cure is stuff that you can cure now, and that's crazy to me. Just earlier this year, they were able to implant a pig kidney into someone as a kidney transplant, which would, if that worked, that would dramatically change what it means to have a shortage of transplanted organs, because you suddenly now have initially animal organs and maybe then even synthetic organs that you could put into people that would extend people's lives in a way that we can't do today. And this was only possible not just because no one ever thought to do it before, but they actually genetic edited the kidney so that it didn't immediately reject when it entered the human. So the sort of thing that the gene editing technology is enabling, new ways of delivering care that you never would have thought possible. And so when people ask me, like, why are there so many people in the hospital? It's like, because we can do stuff like this. This is why people are in the hospital now, is that, 5 years ago, you couldn't even do much of this stuff that's on the screen today. And sickle cell disease and beta thalassemia, things that, you're born with, and you're basically like destined to have, recurrences and have, a lifetime of often painful episodes for a sickle cell crisis. These are things that now look like they may be possible to cure and get sustained remission, again, through the magic of gene editing. So just to say that clinical care is incredibly important, and these advances are the fundamental reasons why we have to now worry about how we deliver these advances to people. But I want to talk about some of the real pragmatic issues that we face and think about kind of healthcare at both the macro level, and then we'll dive into some actual case studies and real examples. So what does healthcare operations look like at a very macro level? At a macro view, you're often balancing inpatient and outpatient capacity. I remember when I was a resident at UCLA, when they were building a replacement hospital for their existing hospital, the new hospital was smaller. And the stated reason was that, well, people won't need to be in the hospital in the future because we will just take care of them at home. Now, they didn't know we were gonna be able to do all this stuff to people and cure cancers that we couldn't cure, and those things require people to be in the hospital. And so now suddenly, there's this great inpatient demand that didn't exist before. Health systems are often changing. So the moment you build a new clinic, that creates new patients for you, new capacity, de-risks many health systems that are not Kaiser, because for them, they're reliant on kind of getting healthy patients on the outpatient side so that they can kind of balance the costs against the more expensive inpatients they have. But then you go ahead and you see a merger, two systems merge, and suddenly that balance gets thrown off. And now you have a lot of inpatient beds, and now you're struggling to fill those beds, and now your hospital's failing, and now you need additional outpatient capacity. And so there's this constant pendulum that's swinging between you trying to make sure you have enough clinic capacity to see people in a timely way, and that you have enough inpatient capacity to care for those people when they actually get sick. And obviously, if there are deep cuts to Medicaid and Medicare, that will fundamentally change what we're even able to do. And so a lot of people now are thinking about AI at the executive level because they see these cuts potentially coming, and they're thinking, what are aspects of our system that we could potentially use AI in that would actually save us money as kind of a driver without sacrificing care? So almost like maybe not triple aim, but like 2.5 aim of like, we don't want to make things worse, but we do need to save money because the system as it is not sustainable from a cost standpoint. At a micro view, what does it look like? Many systems are just individual services patched together. And that's where I was saying, you can be in two different systems that on paper look the same, and yet they feel totally different as a patient, they feel totally different as a clinician, and you often see that at the micro level when you're on service. Almost everything that we have is at capacity. I don't know where you guys are right now in your like local health system. Maybe Mayo Clinic is different, but I would say almost every system around the country is operating very close to, or if not at capacity, just by virtue of the fact that there have been closures of like rural hospitals, closures of smaller hospitals. So the systems that are left after all those mergers have taken place are mega systems where every service is in high demand, and we have an aging population. And so one of the operational things this has led to is this concept of boarding. Raise your hand if you know what boarding is. Okay, so that's actually fewer people than I would have thought, which is good. Boarding is this idea in the ER that a patient comes in, needs to be admitted to the hospital, they're physically in the ER, and they're admitted now, but there's no rooms actually in the hospital upstairs, so they're getting hospital care while they're still in the ER. So in many hospitals, the ER team is not even responsible for that patient anymore. Someone else is. In some hospitals, they send a float nurse down, and others, it's still the ER nurse. So you can see how many patients we have boarding is ultimately a downstream common kind of final pathway towards all kinds of other upstream problems that system is facing at that moment. And it's a very common problem, and it's a problem that very likely you're going to see more press on in the coming year or two as people start to try to measure this across systems and to quantify it, because it is likely, something that's a cause of bad experience and a cause of bad patient outcomes. So is boarding fixable? Interestingly, right before the COVID pandemic, health systems were struggling with boarding as well. I remember I was at University of Michigan, and we were getting emails every day, please discharge your patients early in the morning as soon as you can, because we have a round of patients just waiting for those beds in the ER, and the faster you get people out, the faster we can get people in. And I always found that a little bit laughable, because I'm like, if I could have gotten them out, I would have gotten them out. We're working as hard as we can for individual patients, and yet that's the closest proximal thing that I can do that would fix the boarding problem, recognizing that there's a whole upstream set of pathways that creates the problem in the first place. But during COVID, we fixed the problem. So this is actually a plot from aggregating data from 24 US hospitals during COVID that we had done an analysis on. And while those little lines represent sepsis alerting patterns across those 24 hospitals, the gray shaded area in the background actually is the hospital census across those 24 US hospitals in aggregate. So the numbers are on the right in terms of the number of patients that represents. And you'll notice that when the first COVID case hit each of those 24 hospitals, in the 1 to 2 weeks afterwards, the hospital census dropped. It didn't go up. And this led to a lot of conspiracy theories around the hospital's empty, what's going on. Notice that sepsis alerting actually went up because everyone came with fever, everyone had high heart rate, everyone looked like they were septic. But the census went down, and the reason it went down is that health systems actually tried to prepare for COVID. They canceled elective surgeries. They told people, if you are here for some other reason and you don't need to be in the hospital, stay at home. We'll do everything we can at home because we don't want you to come to the hospital, get COVID, and then have an even worse outcome as a result of that. So it's a fixable problem, but it required operational changes. No amount of IT and AI created this. It was actually health systems choosing to cancel surgeries, lose millions of dollars, and that ultimately led to a bunch of layoffs that actually enabled that capacity, so that had we actually peaked at COVID in a way that many health systems were expecting, we would have been way over capacity, and that was the only way to create that capacity, was to go ahead and cancel surgeries. This is not something health systems are really capable of doing today in this level of way, because this was catastrophic in terms of financial impacts across the country, at least at systems that aren't fully on value-based care. All right, so where are opportunities in that boarding problem where we may be able to use AI to actually tackle it? The first one I'll highlight is measurement. Think of all the places we do chart review. We do chart review to measure quality. We do chart review to look up a set of patients and understand what actually happened when they had a bad experience of care, when there's an incident report filed. And one of the things that actually happened here is I was talking to one of our associate chief medical officers, and he said, for this boarding problem, one thing I want to understand is, are people being sent from clinic to our ER? We have 3 ERs. We have a 3 hospital system, and we have one that particularly has a high volume compared to the other 2. And so we want to understand, are people being sent to the ER from clinic, and are they disproportionately being sent to that ER? What is going on that's creating this kind of lopsided demand? And is it possible that on the outpatient side, we could direct people to a different ER and therefore kind of solve this problem and solve boarding in that one hospital, especially for patients where they don't need to be in that ER because that's our highest acuity hospital. So to do automated measurement, we created a tool called Note Reader. A lot of stuff I'll be presenting today is not yet published, but it's stuff that we're going to be publishing and working on. But this was a general purpose chart review tool that you can use to review individual charts, that you can use to review multiple charts. And so you can give this a list of medical record numbers that has a bunch of individual dates for each patient and ask questions. And this actually uses Llama 4 Scout to answer those questions and create a structured output. I'm not showing you real patient data. I'm showing you kind of what it looks like and blowing it up. But essentially, we took all the notes in the 24 hours before someone showed up in the ER and in the 6 hours after, because that captures some of the ER triage documentation. And we asked this question, was this patient sent from clinic? Answer yes or no. And create a variable name called sent from clinic. You can ask up to like 20 questions. This kind of in one API call allows us to answer all those questions patient by patient. We do a bunch of fire calls and we pull these actual notes in real time. We also have a database of notes that we can draw from for older notes. And the output looks something representative like this, where you essentially get a yes/no answer across all your patients. And then you can now take that, throw it into Excel, throw it into any kind of spreadsheet, throw it into R, Python, whatever your language of choice is, and actually start to understand how much of an issue is it. And so the first thing you want to do is you want to make sure it's accurate. So in the first view that we create, we show you the original text, and it's a note level analysis where you can verify, if the answer is yes or no, was it actually real and was it actually true in the note, and tweak your prompt. And then we have a patient level analysis where we aggregate all the patient notes from that period, and we ask the question over the aggregate of the notes in that time period. So this was useful at a patient level. Our chief medical officer actually did this analysis by hand for 100 patients, and across the system arrived at an estimate of like 30% of patients who show up in our ER are sent from clinic. If it was always sent from our clinic, we wouldn't need the LLM to do this. We could actually check, but we have patients who come from other clinics, and so the only way we'll find that out actually is in the ER triage note where it says they showed up from XYZ clinic. What has this allowed us to do? This has allowed us to turn what is a simple question that required a 100-patient chart review into something that we were able to scale to run it on 1,000 patients, however many we have. We run it only on weekdays and daytime because we assume that on weekends things look different. And so we are looking at opportunities where we actually could redirect patients potentially to one of our other ERs. And we've turned this into a metric that we calculate monthly now. So when we first started tracking it, 40% of patients in one of our locations in La Jolla were showing up from clinic. Over time, that's dropped off a little bit. That's also because of the summer, and we've had some changes in our actual ER volumes. But this is the sort of thing that, had we done this before, we would have checked it once because it was a manual labor effort. We wouldn't have done it every month. But now we've been able to turn essentially a question that is a plain language question into essentially what is a metric that's fully LLM driven. We've shown that you can do this to abstract quality measures. So our SEP1 reporting recently, we switched from fully manual to an AI supported workflow where we actually ended up canceling a contract with a vendor that we were using that had a fully manual process to do this. And we said, well, we actually have an AI tool. And the AI tool actually reads the chart, answers all of the SEP1 bundle questionnaire questions one by one. Individually, that model is 97+% accurate on every single individual question. In aggregate, it's 90% accurate across all the questions. So if any one of these criteria is met or not met, then you don't meet the bundle. And this is just a list of there's like 20 plus questions. So this is just a snippet of those. And when we were doing this analysis led by Aaron Bucina at UC San Diego, one of the interesting things we found is that when the LLM is wrong, in nearly half the cases, you go back and review the chart, and actually the person was wrong, and they missed something. So even the question of what about hallucinations or LLM mistakes? It turns out that when you actually look at something that's super tedious like this, you'll actually find instances of something that got documented that one of our human reviewers missed. And so it's not necessarily just the case that it's the LLM that's wrong when your gold standard doesn't line up with your LLM. Sometimes your gold standard is actually faulty. These next three I'll lump together: simulation, prediction, and intervention. You can't study a system and fix it if you can't simulate it and figure out how it works. And simulation can mean you actually simulate it one event at a time. Simulation can also mean, or we do discrete event simulation with distributions and random sampling. This is actually me playing back our health system in actual real time over a 5-day period a couple months ago. So this is patients flowing in through our system, through our ER, some of them going home, some of them being inpatient and staying for a period of time. The red dots are people who are already there at the beginning of the simulation or were direct admissions through the OR or through our direct admission process. And the blue dots are people who came to the ER, and the green dots are people who got admitted after they came to the ER. So this is something that you can look at. And our ER care volume is super unpredictable. So when we try to do kind of any of these AI-based workflows, we find that this fact that our system is so unpredictable makes this very hard to fix the problem of boarding. On the same day, we might have 60 patients under the care of the ER as we have like 0 patients under the care of the ER, as we have this like just rapid kind of turnover of patients arriving, being discharged, and being admitted, and ending up in the care of our teams. And there's even kind of a seasonality day to day over the course of the week. So you can see here that we have weeks where things are lighter or busier at one of our hospitals, but even within each week, there's this kind of seasonality where things peak on Thursdays, things get light over the weekend, and kind of that process repeats. So if you wanted to fix boarding, another place you could do it is you could look at our scheduled OR admissions. And so, I'm showing you here that Mondays are our busiest day for the OR. This is the number of patients who show up over a several-month period on Mondays outnumbers the people by many, many times the number of patients who are admitted on Friday for surgery, for example. So we thought, well, if we want to level load, can't we move some of our Monday surgeries to Friday? That might mean we have sick patients over the hospital, which is not ideal, but it's the only mathematical way to actually reduce and level load across our census across days is to be able to actually move cases around to different days than what they currently are. So what if we moved 20% of surgical admissions from Monday to Friday? Which ones would we move? We obviously can't move all of them, and we wouldn't want to necessarily randomly move. And so this is where simulation meets prediction, because ideally, you want to actually move the highest risk patients, the people with the longest length of stay. And so the next thing we did was we said, let's predict length of stay. So what happens if you predict length of stay? What you find is that Monday actually isn't the main driver of problems. Even though Monday has the most surgical admissions, if you look at the predicted bed days that Monday is accountable for, it's slightly less than Wednesday. But we said, but Friday is actually an outlier, right? Friday, we don't admit many people. Even though they're admitted to stay, like they're expected to stay a little longer individually, there's just not enough people where it actually adds up to anything. So we said, let's see if we can move some of the Monday patients to Friday and what that would mean. And so this is what I mean by simulation plus prediction plus intervention. Here, we didn't actually do the intervention, but that's something that we would actually, that was a next step, is to actually do this. But the idea here is take the 20% longest predicted length of stay admissions and move them from Monday to Friday, and then rerun the simulation for the system and understand what happens. So what does that actually mean? What it actually means your intervention is you're taking, even though it's only 20% of patients, because it's your longest predicted length of stay of patients, you're disproportionately moving the bed days accountable for those patients from Monday to Friday. So almost shifting half your load to Friday because the outliers are responsible for the longest lengths of stay. And so what ends up happening ultimately, this is the kind of punchline of the story, is that you actually create 3 to 4 beds of additional capacity on weekdays. That can sometimes be even less, like 1 to 2 on Wednesday. But on a Monday or Tuesday, it's like it's a couple beds of capacity that you create at the expense of losing some capacity on weekends. But you can see that this starts to now level load our system across days of the week. Unless we're going to operate on the weekends, this is the best I can do if we need to move 20% of cases around. If we move 30%, 40%, you can imagine that at a health system level, as they're thinking, do we need to open a new outpatient ambulatory surgery center? Do we need to redirect patients and get them surgery at a different hospital in the first place? This is the kind of operating system of, I think, operational AI, is to be able to do basic simulation combined with prediction and to simulate interventions so that you can actually try to understand what is the impact of actually making changes in the system. Resource constraints play an interesting role, and I think I started a couple minutes late, so I'm going to wrap up in about 5 minutes, that's okay? Yeah, okay. So on one hand, the whole reason we ran prediction is because we had a resource constraint that we couldn't just move everyone, and we didn't want to do it randomly. But interestingly, when you predict an outcome, if you don't have the actual resources to handle the result of that prediction, you also overestimate the performance of the model. So for example, if you were trying to transfer patients to the ICU, and you had a model that said 6 patients need to go to the ICU, but you only had a capacity to accommodate 3 patients, your model might be really sensitive and have a, like very high sensitivity, but that sensitivity is meaningless if you actually can't send those patients actually to where they need to go. So your realized performance for these models is often different, and so the resource constraints is a two-way deal. On one hand, it actually impacts how you do the simulation through the role of prediction. On the other hand, it also impacts your performance measures when you're trying to measure this and simulate this in advance of actually implementing it in the system. I'll skip over this. This was just a package we wrote to actually do some of the simulation of resource constraints within a system. I'll skip some of this stuff around forecasting at the system level and some of the stuff that we've done. And I'll kind of close with some thoughts around, can we build predictive AI faster? The way that we often build tools or build AI models and systems look like this. You have 3 use cases, so you separately convene 3 sets of stakeholders. You figure out what data you need to run for each of these different models, and you spend 80% of your time on that step and only really 20% of your time actually building the model. This does not scale, because for every different problem that you're trying to solve, you're disproportionately spending all your time aligning stakeholders and not actually building models. NYU-Tron actually showed us there was a better way to do this, except it's extremely expensive. They fully trained an LLM on their electronic health record, and they supervised, fine-tuned it for several outcomes, and found that it performed better than the equivalent structured model. But even if it performed the same, I would say what they saved here is they didn't have to align a bunch of stakeholders. They could just supervise, fine-tune it, and they would be able to kind of do this. And so one of the things that we're doing, actually, is taking this concept and making it scalable and cheap. And that is this idea of note casting, which is inverting the thinking around how we do predictive AI. So rather than saying you take unstructured data, convert it to structured, and then build your XGBoost model, we flip it around. We say, I ask people, is the information you want to know that would inform the risk of this patient, is it in the notes? And if the answer is yes, we're done. You go home, we'll talk. I might ask you, what information do you want us to not consider about this patient? Do you want us to not consider race? We can do certain things that actually deal with bias. But the key thing is, once they tell me they look at notes, for non-real-time models, most of the models that we use in operations are not real-time models, we can then start with a set of shared embeddings that are trained directly off of patient notes. And we spend almost all of our time just building the model, which is not very much time at all. And so we can build dozens of models, because each model, all I need to know from someone is the variable that contains the timestamp. And everything else ahead of that is starting with the notes through an LLM pipeline into shared embeddings. And then those models are just trained directly off those embeddings. This is our process that we're applying to do this. The goal here is to predict every operational outcome for every patient every day. So you can even have one model that does all this with multiple heads, or you can have separate models. But the point is, this is substantially faster. And that big box, that step, you only carry out once a day across the entire system. The only thing that you need to do when you get a new outcome is to train your model. And once you've got that, this pipeline just kind of works, and you can just apply it every day on patients. And so this is something that we've now started to operationalize within our system, and which we're looking at multiple outcomes to do this, such as predicted day of discharge and things that we need to use to drive actual operational decisions in our mission control. We can beat structured model performance with this tool. It frankly doesn't matter if we couldn't beat it. If we can get roughly the same performance, it's worth it. That 80% time is so expensive that we just don't have the ability to scale it. And so that's where all the time savings are. So even if these were all equal, this is worth the actual effort to do this at a system level. The last comment I'll make before I close is just around automation, which is that chart review is incredibly time-consuming and expensive. This paper out of, I think, Hopkins showed that for a set of quality measures they looked at, every single measure individually cost $33,000 a year. And that's just per metric. And so that is not a scalable thing. Like when someone says, hey, I want to look at how well the ER is doing in terms of where the patients are coming from, I can't think, well, is that worth $34,000 a year to know? Because that does not scale. And that disincentivizes you from actually collecting data and trying to measure quality. And we don't do a good job of it. And there's this great quote that, financial cost aside, if good care is the goal, the greatest cost of all this quality measurement may be wasted time. These hours could be spent in countless other ways. Caring for patients raises the obvious question, is the system we created to fix the system even working? So I think I'll close with this thought that, like Vinny was saying, you can't just take AI and bolt it onto a system and expect it to work. You have to redesign the system. And what LLMs and AI is doing is creating the possibility of us building entirely new workflows. Like imagine a system where an incident report happens because of a safety event. Everything up until the corrective plan is developed is all done through LLMs in concert with documents from your system that describe the system for you. And it's not till the very end that a quality specialist looks at that and says, yeah, that's a great corrective plan, or no, that's not going to work. Because right now, we spend all the time measuring that we spend almost none of our time fixing. So where can AI support operations? I shared some of these examples of measurement, simulation, prediction, intervention, automation. What it takes to get there is really clear operational goals, a really tight connection between operations and IT, accountability, data science expertise and infrastructure, a workforce that has education and is enabled to actually do the work, and definitely you need AI governance. And I'll close with this quote that I think this is still true today. Hospitals are overwhelmed with the number of AI models available to them. And to really understand and use these tools safely, we have to not prioritize problems based on whether there are tools available, but whether the problems are actually solvable in the first place. Thank you.